maybe the biggest thing that was released, I would say not maybe, the biggest thing that was released and was a bit of a surprise, at least to me and to a few others that I know that followed these things, is the introduction of the Advanced Primary Care Management Code. So before I go into what those are, a little bit of background, because this is, especially for those of you who've been in the industry and who might have practiced for a while, sort of this march towards value-based care has been both a boisterous thing that's been pushed, but also has sort of waxed and waned over time. In 2021, Medicare sort of announced that, okay, we've been trying to implement these value-based care arrangements and population health and some capitation models, things like that, right? Stuff that is not pure fee-for-service for a long time. We are going to establish a goal that 100% of Medicare beneficiaries that are in traditional Part B Medicare have some type of accountable reimbursement arrangement at their providers by 2030. So the CMS Center for Innovation were the ones who were basically tasked with strategizing how to do this, testing a bunch of reimbursement models through their innovative model sort of program, and then finding tools to improve the adoption. Kind of how do you sell it? How do you bring it to sort of the forefront, and how do you implement it over time? So last 10 years, they've been doing a bunch of even before this announcement, right? They've been doing a bunch of opt-in programs, that sort of either adjust or replace fee-for-service within primary care. But the adoption is still relatively low. They never really hit on something that was widely loved by everybody. Not that was necessarily the goal, but that was sort of didn't have pushback from a lot of PCPs and other clinics. So how do you introduce population-based concepts to a fee-for-service world to try to pave that way forward? Whether or not that's the way, sort of, we can argue whether or not that's the right way forward. I think when done right, it probably is. But regardless of that, how do we sort of get buy-in and adoption? And APCM is the answer to that, or at least one of their answers to that. So the APCM codes. So I think, and this part is a bit of me speaking versus in the rule. I think they kind of stepped back and they looked at the E&M service side of things. And they said, well, that would be hard to switch over right now, right? Getting paid for the actual clinical visits, fee-for-service is kind of it's a pretty deep part of the system. But all these services that are between visits, the care management services, these seem like something that could be shifted towards a population health reimbursement model. And that's where they started. So they created an advanced primary care management program. It combines the existing elements of a bunch of different care management and technology-based services. So CCM, PCM, transitional care management, virtual check-in, store and forward, all these electronic virtual sort of care services. It takes them and says, okay, if you meet all the requirements of this, which includes a bunch of things that I'll go over in a second, you can bill for every patient that you met those requirements for, regardless of time spent for the patient. It's almost like a pseudo capitation model that exists within the fee-for-service structure that a lot of folks are, that's the most common structure. So you can have a patient population that is in this service. You have to do it in good faith, right? So you have to, if there is time that needs to be spent, and it's not like you could just ignore it, but if you meet the requirements, you don't have to count your time at 20 minutes anymore. You could basically just bill for these patients because they exist and they have access to the services and the requirements of the codes, which is a pretty big departure, right, on the CMS fee-for-service side. So there's 13 elements that are required, which I'll go over in a second. These services, and I think this is one thing that they thought through as well, they're delivered by clinical staff generally. So there's coordinating of care between the different levels, but at the same time, all the services are basically doable by clinical staff. These are codes that allow you to bill for a patient when they have access to certain things, and that doesn't include the E&M, like visit with a doctor, whether it be telehealth visit or telemedicine visit or the office visit. That's sort of put aside, and they're saying, well, if you do all these other things and you're a primary care physician and you're doing, so in the proposed rule it said primary care physician basically. Now they're saying, well, you don't have to necessarily be a PCP or a GP or an internal medicine or family medicine. They're saying, well, anyone who operates out of a traditional or non-traditional primary care specialty. So they left it relatively open as to who could do it, as long as you are the continuing focal point for all the needed healthcare services for that patient. So I won't go too far into what that could include, but by defining it that way, it sort of opens things up a little bit more than it would otherwise. Also, and this was a bit of a surprise, FQHCs can also provide and bill for APCM services, which factors in a little bit in the next slide pretty significantly. So no specific conditions that you have to have, but there's 3 levels of reimbursement for APCM. So again, I'm going to go over the service elements in the next slide, but real quick, just so you sort of see how this looks like, I figured this was worth going through first before we jump into the specifics. So there's 3 different codes. One is a patient who has basically, there's no requirement for the patient to have a chronic condition. If they have 1 or fewer, you could bill $15. They actually increased that from 10, but it's 15 in the final rule for that patient. So not a ton, but not bupkis either for not necessarily doing much, just having things available. For the patients who currently satisfy the requirements for CCM, you get $50 per month. Now, that is less than the CCM code, which I'll show you in a second, sort of a graph between the two. But again, there's no requirement for specific care time spent. The third category is 2 or more chronic conditions on a qualified Medicare beneficiary. A qualified Medicare beneficiary is a term of art that basically it is a patient who meets certain income criteria. I believe it's at or below the federal poverty line, and there's a few different criteria. But once they hit all these things, they fall into a category called the qualified Medicare beneficiary. And those patients, basically, maybe not indigent, but indigent or close to indigent, right? Those patients get paid at $110 per month. By definition, a qualified Medicare beneficiary is also joint enrolled in Medicare and Medicaid. Not all joint enrolled people are qualified Medicare beneficiaries, but all qualified Medicare beneficiaries are joint enrolled. So the the co-insurance that goes with these programs usually does not apply or is covered under that. I say usually, but always in my experience, by sort of definition, they don't have a co-insurance. So that becomes when you have, let's say you're a clinic with a lot of those types, or your patient population is conducive for that sort of folk, suddenly this becomes maybe even more than a CCM program per patient. That's why it's a big deal that RHCs and FQHCs have been allowed to bill for these codes, because if there are places with a demographic sort of composition that leans more towards that, it's the FQHC and the RHC. I'm sure there's others that are outliers, but as far as sort of like a population level, that's definitely a part of that. So great. You can, actually one more thing on this slide. They did say, so Medicare did their normal thing about responding to comments where, everyone always comments, why is there a copay? Get rid of the copay, or co-insurance, get rid of the co-insurance. And Medicare says, we are not statutorily authorized to get rid of we almost like we'd love to, but we can't. So for the first 2 here, there may, depending on if they're joint enrolled or if they have Medicare supplemental, there may be a co-insurance. The third one, there won't be, because by definition, they're joint enrolled and it's covered. But something to think about, right? Because if your patients aren't getting sort of the phone call in the 20 minutes, you have to make sure that during the consent, which is the next segue to the next slide, that they understand that they might be on the hook for that. 13 service elements, and I'll go through them relatively quickly. We're going to put out more information on a few of these that are a little bit less clear, but we'll go through them real quick. So there's the patient consent and the initiating visit. This is already something that's similar with CCM and RPM, although in this case, they said 3 years. So if you've seen the patient within the last 3 years, you can enroll them into APCM virtually without a visit, which is a long time in comparison to the other codes. You have to have continuity of care, right? So a designated team member for routine appointments, alternative care delivery, so you can have office visits, home visits, expanded hours, comprehensive care management, normal CCM stuff that goes with the care plan, right? You're developing and maintaining an electronic care plan that the patient can have access to, that talks through, you do the way you build it is to have a needs assessment, right? You make sure that there's preventative services that they've gotten done. AWV is a big part of that, right? With the scheduled preventative services that goes along with AWV. And then the 24/7 access to care, which is usually a phone number that they can call that triages. Coordination of care transitions. You can tell that they sort of put these together from the other care management codes. They're basically saying offer most of what the other care management codes sort of require, and we won't make you do the 20 minutes as long as when the patient needs it, it's there, right? Communications, ongoing communications about the patient's needs, goals, and preferences. No requirement as far as how much time, but it's there. Population data analysis, which is a little bit, so these last three really. And then 10 is like having secure messaging and a patient portal and just digital communication, ways to talk to the patient that are not phone call or showing up. The last three are interesting because they're the ones that really are somewhat, they're not a departure, but they're somewhat separate from the current care management codes. Population data analysis, identifying care gaps, additional interventions, that's not a huge, it's being done in this case by most folks, most clinics. Risk stratification, not a huge amount of information on what that really entails. But in this case, you're using data to identify and target service to patients. Having a portal that sort of allows you to get that information on a population level and have automatic sort of triggers and things when, a patient might be up for a specific service or need, even things like, oh, it's time for their Cologuard, or it's, you have an annual wellness visit, that sort of things, using the data to stratify and identify. This last part, 13, is interesting. Assess the quality of care, total cost of care, and use of a certified EHR technology. So the certified EHR technology is already required by CCM. Very few Medicare practices that are, accepting assignment of Medicare claims don't have an ONC certified EHR. That said, how do you do the assessment of the quality of care and sort of the measurement of the performance? So there's two ways that they cite. One is if you're doing MIPS, the value in primary care pathway will satisfy this criteria. If you're in a shared savings program ACO, you're a member of an ACO that's participating, that also qualifies it. And then they're not very clear on what other sort of sets of things may or may not. They say that they're explicit that they're going to issue more guidance on this last one. So if you're not doing the value in primary care MIPS pathway and you're not a member of an ACO or doing the shared savings program, they're basically putting out more information on what that might look like. And we're going to be, so we actually just planned one of our blog posts coming out is literally how do you, satisfy performance measurement under APCM. And we're putting that together, and we're also waiting for that guidance, and we'll be updating what we got at the same time. So because APCM includes a bunch of the different care management codes, you can't bill for the care management codes that are included at the same time as APCM. So if I'm a provider and I'm doing APCM on a patient, I can't then also do chronic care management on a patient. During the proposed rule, they said also another doctor couldn't. They said basically that APCM would cut off any provider from doing CCM. And there was some upset about that because if the primary care doctor is doing CCM and maybe the cardiologist is not, and then what if the cardiologist is doing CCM and the primary care physician is doing APCM, and it basically they backtracked on that and they said, okay, the same doctor can't do both. It's not billable by the same provider, but another provider can. So you can have the primary care provider doing APCM and the cardiologist or the rheumatologist or the pulmonologist or whatever it might be do CCM on their side, which is a big deal, right? Because a lot of, especially A lot of specialists don't want to, one, they don't want to upset their referral sources, which makes sense. And they don't want to do something that means that the other folks can't bill for a thing. But also, it allows both the primary care physician and the specialist to both basically do a care management service, where before you had to do PCM, which was not as basically didn't pay as much and also was much more confined in what you were allowed to do. So that's the meat and potatoes of APCM. We're doing another webinar that's going to go further into those that like specifically that code set in early January that we'll be sending out, and I can share. That we'll share at the end when we send out the recording of this webinar. But just to talk really briefly, because this was a big part of the final rule, that there was a lot of I don't know, maybe dicta. I don't know exactly what you call it. A lot of CMS pontificating on how the future of APCM can really bring about more like hybrid pay models and serve as a chassis to incorporate primary care model learnings into primary care, fee-for-service primary care, which is interesting. So they did a request for information on this concept of the advanced primary care hybrid payments sort of strategy. And they asked about, well, how can we streamline value-based care opportunities and accountable care? And how can we bundle E&M services and visits into APCM payments without, disincentivizing the visits? And how to structure the payments for improved patient experience. And basically, they were not subtle with the fact that they see this as sort of the first salvo in, maybe salvo is the wrong word, because it's the first, I don't know, their first major foray into building out a population health, the population sort of model reimbursement, accountable reimbursement structure within the fee-for-service realm concurrently, right? Hybrid, where you have both going on at once. And how can they expand that out more? So that, again, their goal is by 2030 to have 100% of the traditional Medicare patients, have some sort of accountable care at the places that they go to receive care. So huge change. That's all I have to say about it on this webinar, but we will have another one because it is an interesting just movement in the industry, but also will be particularly interesting in implementation, because they weren't as clear as I mean, it's in their defense, it's difficult to sort of specify a huge new program like this in a way that like hits every permutation that you might come across. But even still, there's some things that need some more guidance for sure, and we'll be helping out as that comes through.